taking a break does to you. All right. Okay, hormones. So, how we're controlling the GI tract. These are all chemical communicators. In order for hormones to work, the receptor must be on the cell. So when we dump gastrin into the bloodstream, the only cells that are going to really respond to it are the parietal cells. Parietal cells make HCl. So they're going to start producing this. So when do you need, or when would your stomach produce HCl? When there's food. So when I'm actively eating and food is entering my stomach, gastrin is released. Histamine, same thing. When it's released, it increases production of HCl. So we should see it when I'm eating. Secretin. Secretin stops acid production and then produces or makes the pancreas release bicarb, that buffer to defeat the acid. So what point in time would I see this production? When should I see secretin released? When there's food passing the pyloric sphincter. So when food is entering the duodenum. Okay? Don't try and just memorize these. You're going to confuse it. Do you see how I'm trying to walk it through when it's related to food? Try and think of it that way. CCK. So this causes enzyme release from the pancreas. It activates the liver to produce more bile, and it makes the gallbladder contract so that that concentrated bile can come out. So once again, when would I see this produced? When food is passing through into the duodenum. Okay, we already produced that chyme, it's been churned up, and we're pushing it out into the duodenum. Now we're breaking it down. We're digesting it so we can absorb it. Parasympathetic vagus stimulation, that's rest and digest. Well, I should see acid. If I'm resting and I'm having food come in, I should see acid production. So if there's stimulus of the vagus nerve, the GI tract is stimulated, so we see acid production. Enterogastric gastric reflex, okay? So when food is now passed through the stomach and we're entering into the duodenum, it starts to shut down the vagus nerve or offset the vagus nerve through sympathetic stimulation, and then we see the production of the stimulation of the glands in the duodenum to produce that secretin and that CCK. All right, so when you're sitting in class and you're really bored and it's lunchtime and you're sitting there and you start thinking about food, your brain has an internal clock. When you get older like me, you'll notice, like you just start waking up in the morning before your alarm clock, and it's the most frustrating thing, right? You will learn to wake up at a very specific time. You train your body. When we talk about, or when you talk about like sleep and what is the best thing for sleep behavior, it's a set bedtime, set wake up time, even on weekends, whatever. So if you are consistent with that, your brain learns this is when I shut down, this is when I wake up. And so the brain has an internal clock. So when it's, around lunchtime, even if you're not really hungry, it starts to think about food and can stimulate the satiety center to where you're hungry, okay? So, and you guys, if you've taken a psych class, this is like Pavlov's test, if you guys learned about that, where he took the dog and he trained the dog, like ring the bell and then give him the food. And eventually what happened? He could just ring the bell and the dog would start to salivate and all of that. Same thing in us, okay? So when you see food, smell food, thinking about it, the activity of the stomach increases. So we have parasympathetic stimulation, vagus stimulation, gastric activity, or release of HCl. Okay? Gastric phase, this is where food is in there. So because food is in there, we'll see that stretch of the stomach. The stretch of the stomach relays back to the brain that we should have satiety, we should have fullness, feeling of fullness. It takes a little bit, right? And we'll release that gastrin, and because of that, we'll increase the production of HCl. We'll also see that these three guys work on the parietal cell. We mentioned histamine and acetylcholine. All of these work on the parietal cell to produce more HCl. So when you talk about like medications to stop like acid, that's where we work. We try and work on the parietal cell or block the histamine. So like the old school antihistamines were used um, for reflux. Okay. Intestinal phase. So this is where the chyme has gone into the duodenum. Now we're shutting down the stomach. So we decrease gastric production. We should see secretin and CCK come up. We should see bile dumping into the pancreas. We should see all the bile dumping into the duodenum. We should see liver upregulating and producing more bile. The gallbladder contracting. The pancreas releasing all the enzymes to break down the food. High bicarb numbers. All of that to offset the acid that's mixed in the chyme and to break down the food. All right, so here they're showing this is the parietal cell. These are the receptors for gastrin, acetylcholine, histamine. So this is blood side, and then this is stomach lumen inside the stomach. This right here is going to chase us all semester, this equation. This is the equation we'll see in the lungs, how we get rid of hydrogen ion in the red blood that's carried like in the red blood cell. We see it in the kidney. That's how we pee out hydrogen ion. So this system, this bicarb buffer system, will constantly chase us. Okay, so keep this in mind. All right. So when we talk about, proton pump inhibitors, they're working on these receptors to block them. And by doing so, we don't pump in hydrogen, we don't pump in chloride. Well, we don't pump in hydrogen, we do pump in chloride, okay? All right, this is a nice image because it shows all the different situations or release of hormones and what they're acting on. So it's good for you guys to go through for a visual representation of it, okay? Here they're showing CCK being released into the bloodstream. There is an effect on the pancreas directly, and that's just to increase like secretions. But really for us, the big focus is liver, gallbladder contraction so that bile comes down. Okay. Small intestine. So we have three portions of the small intestine, duodenum, jejunum, ileum. You'll hear duodenum. Okay. I think the British typically say duodenum. All right, so duodenum, C-shaped, because of the way when it's connecting and folding during embryology, you'll see some is intraperitoneal and some is adventitia. So you'll see serosa and adventitia, or retroperitoneal and intraperitoneal. Okay, just depends on the portion. And C-shaped, pancreas sitting in the C. When you guys look at it in lab with the cat, you'll see how the duodenum kind of curves around, and then the pancreas is kind of in the fascia there, wedged inside of it. And it's very clear. It's like this, they always reference it as like a beefy tongue structure. I don't know how they came up with that, right? You'll notice, especially in micro, everything's related to food. Okay, so duodenum, couple unique things here. One, simple columnar, that's pretty standard. We'll see that throughout the three sections. We have villi, which are big folds, and then we have like little hairs on the villi. That's the microvilli. Wedged in those little hairs are the brush border enzymes. That's where you're going to find like lactase, sucrase, all of that. Increasing surface area. By increasing surface area, we increase absorption ability. When you talk about in diseases like celiacs, they cannot tolerate gluten. What happens? The villi blunt. They turn flat. So now when they eat, the food just slides right past. They have horrendous diarrhea. Constipation is not a symptom of you don't do well with gluten. You either have celiac disease or you don't. Okay. Um, the plicae circularis, these are just bigger folds where they take all of that structure and fold it. And they're bigger ridges to help slow the food down, catch it in there, and absorb from it. Goblet cells, these are just any simple columnar cell that is producing mucus. Okay. Paneth cells, these make lysozyme. You'll find lysozyme in every secretion in the body. It destroys gram-positive bacteria, their cell wall specifically. Enteroendocrine cells, this is what we talked about, production of CCK, secretin, that's once food is in the duodenum, and then lacteals for fat absorption. Remember, fats, we wrap them with a protein. They go through the lacteals into the lymphatics before entering bloodstream. So here they're showing these are the villi, and then we get these big old folds of the villi. That's plicae circularis. And on the surface of the villi would be the little hairs, the microvilli. Whoops, like jumped, okay? So here they're showing the endothelial cells. There's the microvilli, they're extension of the cytoskeleton. And inside of the villi, you would find all the different vessels. So we need to supply it with blood, take the deoxygenated blood that's, here's a good question. What would be in the deoxygenated blood? Anyone at home? What would be in the deoxygenated blood? What's the entire purpose of the small intestine? Absorption. So what would you find in there? Nutrients. All the nutrients are going to start to appear in here. In the duodenum, maybe not as much because we still haven't broken down everything 100%. Some things have broken down, okay? So it's going to enter into the venous system. This is a capillary bed, and what we're going to see when we talk about the liver, that's the next stop. So between the two, we call it a portal system because it's two capillary beds. We're sending high nutrition to the liver in that deoxygenated blood, okay? And then in the lacteals, fat. So here, they reference this as a goblet cell. Really, that's a mucus vacuole. The cell, the entire cell is the goblet cell. Crypts are not, they're technically not deep in the tissue here. They are the gaps between the microvilli, and then there's little holes that go down in, but they're considered external. A crypt is like a cave, a cavern. And so it's just a point down in there, okay? All right, submucosa. So we have a unique feature here when we talk about the duodenum. So remember, we have mucosa, submucosa, muscularis externa, either adventitia or serosa. Unique feature in submucosa. Remember the unique features. Here is Brunner's glands. Brunner's glands are unique to duodenum. They produce bicarb and mucus. Tons of it. We must have tons to offset the chyme. The duodenum is not designed to have acid touching its epithelium. Just like the stomach, the epithelium is not designed to tolerate acid, so we have mucus. But here in the duodenum, we have even more production of mucus to protect it. So that's Brunner's glands. All right, so what's coming into the duodenum? The chyme, it's acidic. The bile from gallbladder and liver, and all the bicarb and enzymes coming out of the pancreas. So all of this is mixing together so we can start to digest the food fully so that we can absorb it. So fats, we don't break fats until we hit duodenum, and we use lipase. Carbs, we did start to break down in the mouth, but that amylase that's there gets destroyed. And so once we hit duodenum, here's the primary amylase coming from the pancreas, and we use it. And then the proteins, the zymogens, those are activated because otherwise they would destroy the tissue itself. We activate them, and now they can break down all the proteins into the amino acids. Jejunum, this is where we do a majority of absorption. Okay. We use brush border enzymes in here to break down like your dipeptidase or your dipeptides that are still floating around. So jejunum has villi, has microvilli, but it does not have plicae. No, it does have plicae circularis. Correction. Both of them have. Okay, it has the big folds, but we get rid of Brunner's. At this point, we've buffered the acid. We've gone pretty neutral. Okay, so we do not see Brunner's here. The big claim of fame for jejunum is absorption. Majority of absorption happens here. And muscularis externa serosa. Brush border enzymes. Okay, this is our fine tuning. This is what breaks down those disaccharides so we can absorb them. Remember, they must be monomers. They must be monosaccharides for us to absorb them. So we use lactase, sucrase, maltase to break down lactose, sucrose, maltose. Dibeptidases to break down those diamino acids. Okay, and then we can absorb them. Mucosa of ileum. So ileum has a unique feature here. Ileum is the last section before we go to large intestine. In the small intestine, there really isn't bacteria. Because think about it. You went through the stomach, the acid would destroy it. Once we go through small intestine and we hit large intestine, there is bacteria there. Tons of E. coli, Pseudomonas. It just depends on the person what you're going to find in Enterobacteriae. Depends on the person what populations or colonies that they have. So the problem is bacteria can climb back up into the small intestine. So what we find in the mucosa near the surface, Peyer's patches. We also see they can penetrate into submucosa. So you'll see them in both sections. Peyer's patches are the equivalent of like tonsils. They're an aggregation of white blood cells. Okay, so we call these like MALTs, mucus-associated lymphatic tissue. I have seen a situation where there is MALT. It can be random. A maltoma, so a cancer in a lady's stomach. So she had an aggregation of these types of cells in the stomach, and it developed to be cancerous, and it was actually pretty severe. She was younger. She was passing black stool for quite some time and didn't tell anyone. She was bleeding, the blood's being oxidized. She was like probably in her 30s. She had a kid like yay tall. And I remember my preceptor was like, she's not going to survive. I can just tell you already, she's not going to survive. It was very aggressive how much it had spread. So listen to your bodies, people. Something weird, go get it checked out, right? That's why I take my wife to the doctor frequently so she gets checked out. Speaking of food, just when you think it, vegetables can't call you, onion rings. Come on, onion ring? No? All right. All right. Thanks, Jerry. Gotta laugh. It may have been a pity laugh, but it's okay. So Peyer's patches, tons of white blood cells, and we'll talk about white blood cells specifically when we get to immunology, okay? So the other reason for this is any entry point to the body, we need to poke the immune system. I always say the immune system's like a sleeping bear, and you got to poke it and keep them stirred up. If you don't keep them stirred up, it gets lazy. It starts to slack off. Your immunity wanes, becomes weaker. So having this here and sampling that bacteria that's always kind of stimulating it a little bit helps actually keep our immune systems more active, more potent. That is why, they usually don't pull tonsils out anymore. unless they're really causing obstruction or repeat strep throat infections. Because what we learned is when we get rid of them, people's immune systems tend to be a little weaker because we're not poking that bear, that entry point into the body. So we kind of weaken their immune system in that situation. Same thing with appendix. Now first line treat for appendicitis is actually admit the patient and give them antibiotics. Before it used to be, oh, you got appendicitis, let's take it out. Because what we've learned in the appendix is that there is part of the immune system as cell types like this in there. Okay. But Peyer's patch is just unique to the ileum. Everyone has it. And so that's why we teach it, right? And here they're showing big areas of it. Same thing here. And it can get into mucosa and submucosa. It penetrates into submucosa. We talked about peristalsis, that's movement. Segmentation is to like mush it up, mash it up, mix it so that we can have more absorption of nutrition. So large intestine. So we have appendix right there. And they used to refer to it as vermiform. I don't know if they still refer to it as vermiform or not. Vermiform means it's like it's kind of like vestige organs. So it means it's old and we don't really use it, but we kind of learn now immunology wise that we do. Right? So appendix, ascending colon, transverse colon, descending, sigmoid, and rectum, anus. Okay. So here, we're not doing any absorption. We get rid of the villi. It's just mucosa. Because we are pulling the water out in the jejunum, we pull out like 90%, I believe, in the jejunum and or is it ileum? Jejunum. I think it's jejunum. Okay. We leave 1% of fluid remaining in the stool because we need water to allow the stool to pass. And that's why you see a lot of goblet cells, mucus cells to lubricate the passageway so the stool can pass. Number one cause of constipation, lack of proper hydration. Okay. Lymph nodes, that's aggregations of white blood cells. That's all that really is. Submucosa, nothing unique. Muscularis externa, we have a unique feature here. Here, the outer longitudinal layer is contracted. So we have this line passing across. That's what they're talking about. And that is Taenia coli. So the line is Taenia coli. These like little areas they look segmented, those are hostra or puckers. When you guys when you guys dissect the cat, will you see them? Hostra or puckers. Will you see hostra or puckers in a dead cat? Are your muscles going to be contracted when you're dead? Right? So initially, rigor mortis initially, but after that, the calcium dissipates and the muscles don't contract anymore. So when you look at the cat, you won't see it. All right. Serosa for transverse sigmoid, adventitia for the remaining. So it was jejunum. 90% of absorption in jejunum. And we really pull out the remaining 9% large intestine. We leave about 1% or so for passage of the stool. Hydration is key. So feces, if you eat too much, you don't have enzymes, or you eat food that you just don't have enzymes for, can't break them down. So like cellulose, you eat celery, that's all undigested and needs to pass through it. Tons of bacteria. We need the bacteria. the reuptake of bicarb. We don't want to lose too much. So when you have patients that are abusing laxatives, so that's a form of anorexia. You'll see it in that population. They abuse laxatives so that they can just pass stool quickly and not absorb the nutrients, but they're eating, right? They tend to have acidic blood. That is a sign. And then if you look on pathology, when you look at like the white blood cells that are captured from there, you actually will see like in the house inside them stuff from the laxative, and that can be an identifier there. Okay. So they'll become acidotic. You notice like breathing is rapid. They're trying to get rid of hydrogen ion. So those are other signs. Bacteria necessary, so we make those clotting factors, that vitamin K, which is used for making clotting factors, I should say. Right? Vitamin B, different Bs that are generated that way. All right, we shed epithelial cells constantly, slough off, we replace them, no biggie there. Rectum and defecation. Okay. Stratified squamous, we're exiting the body. So we'll see stratified squamous. It can take abrasion and replenish, right? Oops. We have stretch receptors. Remember, we stretch the internal sphincter. That sends up the signal. When it's appropriate, we release a signal down to relax the external sphincter, and stool will be passed. Okay. This is a good image for you guys. It covers all the different tissue types, like unique features, stuff like that. So it's a good chart. If you want to snap a photo or whatever of it, I'll give you guys a second. Screenshot it, whatever you need to do. And you guys can always go back in the video and grab it. Okay. Accessory organs. So these guys, teeth, salivary, liver, gallbladder, pancreas, they're involved in like mechanically mashing the food, for example, supplying enzymes, but remember, food is not going through them. Okay. So tooth. Enamel is the exposed portion. So we require calcium for it to be formed correctly. Dentin, that is this lower portion in here. Pulp cavity, that's where we find nerves, vessels. And periodontal ligament is what is keeping the tooth to the bone. Okay, it's mating the two. And then gingiva is the gums. Gingiva has two layers, stratified squamous because of like abrasion, stuff like that, and then lamina propria. Crown and root. So crown is everything above the gingiva. Root is everything below. Okay. So the enamel, just for your own knowledge, curiosity, when you go and you have a cavity, okay, just a little bit like that, that's when your dentist says you have a cavity and you don't feel anything. It's just started. The bacteria are fermenting the sugars, the foods that we eat, and they're producing acid. Acid is like one of the worst things you can hit your teeth with. So going back to like bulimics, for example, their teeth are usually very eroded from vomiting so much. One of the worst things you can do, in my opinion, is put like lemon in your water. A couple drops of lemon in your water drops the pH to like 2. Just a couple drops. That's all. Doesn't take much. Like my bio students, they do an experiment with it and they measure it, and after like 2-3 drops, it's down at 2 pretty much. Very, very acidic. But that's why like sodas are bad, because they have the sugar and they have like citric acid in there, stuff like that. It's acidic. So be weary of that. Now, as that decay continues into the dentin, when you eat or drink cold drinks, eat hot things, stuff like that, and it hurts, that's where you're at. You're starting to excite the nerve in the pulp cavity. If you continue to ignore it and it gets down deeper into the dentin or hits that pulp cavity, it is raging constant pain. Okay. When you get deep enough in the dentin, that's where they do a root canal. Root canal is they literally go in there, they stick a file into that pulp cavity, and they rip out the nerves and the vessels. Then what they do is they put like a post usually in there, and then they put cement in there, and then we mount the crown on top to protect the tooth because the tooth's integrity is gone because you've hollowed it out. So that's the process there. Okay. Um, it's dangerous to let it get that far because now this is a portal for bacteria to get into your bloodstream. So then it attacks your heart. You develop what's called endocarditis. It destroys the valves in your heart. You develop murmurs. You may need heart valve replacement. So important to deal with that. There's your little dental lesson. Okay? Oh no, I don't want the annotate feature. There we go. All right. Salivary glands. So parotid, submandibular, sublingual under the tongue. Parotid, watery serous solution. So the ducts tend to be a little longer. Mumps infection. So mumps and bumps. That's part of your MMR vaccination. Mumps, measles, and rubella. Mumps, when it infects the parotid, it's extremely painful. It gets hugely swollen. And then in males, it actually affects the testicles also. And it causes what's called orchitis, that is infection of the testicles, and causes sterility, permanent sterility. So all these people that are anti-vaxxers, they don't want to give their kid MMR. If it's a boy, they catch mumps, they could be sterile for life. Okay? No children. The parotid can become obstructed. The ducts can be obstructed. It is a longer duct. My dad's told me before he's had to go in there with like a probe basically, and he'll find like the duct, one of the duct exits, and he'll probe in there, and a stone will come out. Some people will form stones in there, and it obstructs the duct. They'll come in, huge swollen parotid, extremely painful. And the second he does that, just like saliva pours out, and the patient gets relief. Submandibular, it's a mix. And so that's why you see serous and mucus secretion when you talk about the acini in there. And then sublingual mucus, short duct, so it typically does not become obstructed. That's the one when you yawn, you squeeze it, sometimes you see like saliva shoot out of your mouth. That's what we're talking about there. All right, so they're exocrine, it's exiting the body. You guys learned about this in lab, serous acinus, watery secretion, mucus, or acinus, mucus secretion, okay? Cuboidal for ducts. Saliva, we produce a decent amount. It's hypotonic. Why must it be hypotonic? What does that mean? It doesn't have solute. Why do you want your saliva to not have solute? What happens if your saliva had sodium chloride in it? Salt. What are you going to taste all day? Salt. What are you going to taste when you eat your food? Salt, right? So that's why it's hypotonic. It would alter the taste of everything. And then mucus, lysozyme, antibodies. Whoops. We're not moving enough. The light's turned off. Come on, light. There it goes. All right. We're back. So IgA, and we'll talk about the different antibodies in immunology, but IgA is like in all the body secretions. That's where you'll find IgA, one form of the antibody. So it stands for immunoglobulin A. Okay. Control, facial, glossopharyngeal. Remember that cephalic phase. You smell food, think about food. You stimulate production of saliva. Okay. Medulla plays a role in it. And if you guys remember in AMP1, like limbic system, when you talk about like food, you smell pie, it makes you think of grandma and good feelings, that kind of thing. That's limbic system. Liver. All right. So liver, 4 lobes. So we have, remember, patient's left, patient's right. And then on the back side, we'll see the caudate, which is tail. It looks like a tail. And then our quadrate lobe, which has 4 sides, quad. Okay. Hepatic portal vein. intestine to liver. Remember, we said on the venous side of all those like villi in the jejunum, duodenum, okay, what's going to be in there? Nutrients. We absorbed it all. Here they say no oxygen. Deoxygenated blood does not have no oxygen. It just has lower volume of oxygen. Okay. Hold your breath for 30 seconds. You don't suddenly die. Right? There's oxygen still on the hemoglobin going around. Okay. Deoxygenated. There's less oxygen. So we're sending nutrition to the liver. We have to supply it with oxygen. We're saying there's less oxygen there, not sufficient. Okay. So this is where the hepatic portal artery comes into play. This is supplying that oxygenated blood to the liver. Then we're going to filter everything in the liver. We're going to exit the liver. And on our way out, we'll enter the inferior vena cava. Inferior vena cava is what's going to go back to the heart, nutrient-rich, deoxygenated blood, and it'll go through the heart, lungs, back to heart, out to body, okay, with that nutrition in it. So when we look at the liver, we have lobules, so there'll be these larger areas, and then the cells making it up are the hepatocytes. These are what are going to do the filtration of all that food coming in, or alcohol. So they're going to do detoxification. So any medication you take, they're going to break it down potentially and work on it. The organelle that would be predominant in here would be smooth ER, because smooth ER does a lot of detoxification, creation of glycogen, all of that good stuff. Okay. Sinusoids are like little streets between here. So if you think about the hepatocytes like buildings in a city, sinusoids are the roads. The cars in the roads are the Kupffer cells. The Kupffer cells are macrophages. So they're sampling. If anything made it into here, they're defending. They're part of our immune system. Then we hit the central vein. Central veins combine and then exit to be the exit to the inferior vena cava. Okay. Hepatic triads, there's a misconception about this. It doesn't mean that you find just these three: branch of hepatic portal vein, branch of hepatic artery, and branch of bile duct. In reality, a triad is you have a lobule, there's the central vein, a lobule, a lobule. If you connect the three, that's truly what they're saying. Here, you'll find those three vessels. Okay? Arteries, always very thick. Veins, large and maybe kind of flattened. Arteries usually are like perfect circles. And then ducts, what cell is always lining a duct? I think I heard it. Cuboidal. So you find those cuboidal cells, that's always a duct. You may find two arteries. You may find two veins, two ducts. Don't panic by that. Okay? It's just there's variations in tissue. So which way are we going? We're bringing in nutrition in the hepatic portal vein. We're bringing in oxygen in the hepatic artery. That will go towards the center, towards the central vein. So we're pushing it from this region into here, into here, into here. Bile is created by the liver, by the hepatocytes. That's exiting into the bile canals. So that's what they're saying here. Blood, hepatic portal vein, rich in nutrition, artery, rich in oxygen, pass through the sinusoids, central vein, hepatic veins, inferior vena cava. Bile, because the hepatocytes are making it, enters what are called bile caniculi. They're like little canals on the way out to that bile duct, out the left and right hepatic duct and common bile duct, duodenum. Okay. So right hepatic duct, left hepatic duct. Common is once they combine. This is cystic duct coming off the gallbladder. And then we continue on with the common bile duct. One cystic combines with common hepatic duct, and we combine with the pancreatic duct, and we get an opening here. That opening has a shape. Just draw it on the board. If you guys ever heard of an ampule, like for like back in the day when they would have solutions that you're going to draw up for a patient into a needle, it would be in what's called an ampule. An ampule structure pinches in like this and then had like the head like this. That's an ampule. So what's happening in the body and why they named this is the ducts are coming in like this, and the ampulla of water looks like that structure, and then we exit into duodenum. Okay? We pass a sphincter here after the ampulla of water, and that sphincter is called sphincter of Oddi. When that closes up, say we're not eating, there's no parasympathetic secretion or stimulation, we're not eating, we're not releasing CCK, we're not releasing secretin, there's no food in the duodenum. Sphincter of Oddi closes. When it closes, there's backup. Backup, 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 bile drops into gallbladder. Now it sits and concentrates. We pull the water out of it, we concentrate it. Next meal comes, sphincter of Oddi relaxes, CCK is released, the gallbladder contracts, and we push it out. Okay? So the liver is insanely important for us. When you have liver failure, it is death unless you get a transplant. There's like a very rapid decompensation of patients when there is liver failure. Okay. There's a neat show. I can't remember what we watched it on. It's True ER of like New York or something like that. I think it's on like Netflix, and it's actually real life, real doctors, nurses, teams. And they had a patient on there, and she came in and she was fine, and then all of a sudden her liver started immediately failing, like just for some reason shutting down. I think she had like an idiopathic disease where like the liver is just being attacked for no reason. And within like an hour, she was unconscious. It did not take long. And they ended up getting her a transplant, I believe, and she survived. So it was kind of wild. But yeah, it's a good show. I can't remember what it's like. It's something ER, I think. But it's neat. They show like even the helicopters, the trauma nurses, all of that, trauma teams. Pretty wild. Okay. So liver, we've got blood coming in there with nutrition. We have blood coming with glucose or with oxygen. And what he does is he removes all the components or a lot of the components to build, to store, to prepare them for the rest of the body. Then we break down toxins, like I mentioned, so medications that are metabolized by the liver. So this is where, when a patient has like hepatitis, for example, or cirrhosis of the liver, they're not producing enzymes like they should. They're not detoxifying like they should. So when they start to consume certain things, you can see elevated levels in the blood. So like dosing has to be adjusted at this point. Most harmful things to your liver are alcohol, Tylenol. Tylenol is it damages it pretty aggressively. So you see like even patients with like arthritis that are popping Tylenol all day, you can start to see damage in their liver. And that's part of the reason, if you ever heard of like, they've actually created now where you get hydrocodone alone, because hydrocodone is usually paired with acetaminophen, which is Tylenol. So they've unpaired it to where it's just hydrocodone. That way the patient can max out on Tylenol. If they're still having pain, continue on with the hydrocodone for pain relief. So when I had like my knee surgery, for example, I had massive knee surgery a few years back, and I hit a point after the nerve block wore off 2 days in. They did a femoral nerve block. It wore off. Pain. Okay. I had bone cut. I had several screws put in, ligaments replaced. Pretty intense surgery. Um, I was writhing in bed. That's how I would term it. Sweating. I turned pale, very pale. I am brown and I turned very pale. It was massive. My brother-in-law like unwrapped it, and then him and my wife are having a discussion. My wife's the pharmacist, he's a surgeon, okay? And they are arguing about giving me more pain meds. And he's like, you got to give it to him. You can't leave him like this. My wife's like, no, he's maxed out on Tylenol. He's like, you can't leave him like this. We're going to take him to the hospital. They're just going to give him, pain meds. It's one and the same, like the little bit of Tylenol, not a big deal. And the best part is they called the surgeon and like the surgical nurse answered, and my brother-in-law was like telling her, he's like, I unwrapped it, it's extremely inflamed, and she started yelling at him. He's like, ma'am, I'm a surgeon. He's like, oh, you're good, you can unwrap it. Right. But yeah, I ended up taking 3 hydrocodons back to back, and that took the edge off. And that I started chasing the pain was the issue, and then I was taking a hydrocodone every 4 hours in order to deal with the pain. So, not fun, right? Um, so we also generate a lot of things. So here's where we see that albumin. And when you talk about like liver failure, they develop what's called ascites, this fluid in the gut. Okay, and what's happening is, and we'll learn, albumin holds on very powerful to water, creates what's called osmotic pressure, holds it in the vessels. So when they have liver failure, like in cirrhosis, you lose that production of albumin and the water starts to go into the tissue. It's third spacing. And so that's where you get these ascites, this big fluid filled belly. You could hit one side and it literally moves like a wave. It has to be drained. They can develop spontaneous peritonitis. So in the peritoneum that we talked about becomes infected. And that's what they usually die from in the end. Okay. Those lipoproteins, so that's the protein attached to the fats so that we can transport it, and then clotting factors. So you'll notice like they bruise easily when they have cirrhosis. They get a cut, it just continually bleeds and whatnot. And then storage. We generate glycogen here. Glycogen is just glucose attached to glucose attached to glucose, so we can use it later. Spleen, this should be spleen, right? Yeah. Spleen, sorry, we're referencing spleen. We have an aggregation of macrophages in there. So as your blood only lives 120 days plus or minus a week. That's all it's really good for, the red blood cells. So as they start to degrade, as they pass through the spleen, the macrophages literally bite them. They take bites out of them. They're called bite cells after that. You'll see them, they're missing a chunk. And we break it down. Well, the body's going to recycle if it can. So we have the heme and the globin. The globin is a protein structure. I'll just break it down to the individual amino acids, recycle it into whatever. The heme has that iron component in it. So what we do is we have to convert it. We convert it to bilirubin. Bilirubin is not water soluble. So we attach it to albumin. Then, because we attach it to albumin, we send it to the liver to be undergo what's called conjugation, the true formation of it, so we can secrete it out of the body. We either secrete it in our urine or in our stool, and that's what gives your stool like the brown color. It's that heme coming out in there and being oxidized between the bacteria and the air in there. Okay. So when you see like cirrhotic patients, what's another feature that they have? What color are they usually? Someone has cirrhosis, liver failure, hepatitis. What? No? Yellow. They're yellow. It's jaundice. The whites of their eyes are yellow. The skin, because that heme is accumulating in the body and it's slowly converted over to bilirubin, and we get that yellowish color throughout the body. Okay. And the stool usually turns pale colored because they can't conjugate it and excrete it. All right, gallbladder. He really doesn't do anything unique other than concentrate bile. There's really no uniqueness in here other than no submucosa. He just reabsorbs water to concentrate bile. So concentration of bile, that's reabsorbing water, ions out of there. We're just making a concentrate. What is bile made up of? Bile salts, cholesterol. Okay. Bile pigments, there's that bilirubin, ions, water. That cholesterol factor is why we develop gallstones. That's the reason there. Okay. Um, CCK, remember, causes the bladder, or not the blood, the gallbladder to contract and secrete that concentrated bile. Here they're showing if there was a stone, what would happen. When you have these stones, if it's here, everything backs up. So we start to see pancreatic enzymes in the bloodstream. We can see pancreatitis, and then we start to see that bilirubin build up in the bloodstream. If it's just up here, just the bilirubin builds up in the bloodstream. You can see like liver enzymes increase, stuff like that. That can be an identifier that they have gallstones. That's a gallbladder. There's the gallstones all in there filling it. This is a gallbladder. Those are gallstones right there. This is gallbladder cancer. They call it like a porcelain wall. It'll start to get bright like that. That's a sign of gallbladder cancer. And these are just ultrasounds. So on ultrasounds, we can identify it. Excess cholesterol in the diet is the biggest factor for creating gallstones. And then being female. Because females produce high HDL, the HDL production actually helps them secrete cholesterol. So they always say if they're female, fat 40, I think that's like the saying. Those are like risk factors for having gallstones. And how do you know someone has gallstones? What do they complain of? Pain. It's pain, but where? Not here. Here is appendix. Right shoulder. It is referred pain. Okay, back pain. When they eat and that gallbladder goes to contract and it can't get the stuff out, pressure builds because of the way nerves are run. We get referred pain. Right shoulder is typically where it's seen. Okay. Pancreas. So, pancreas majority is exocrine, serous. So he looks identical to parotid. The difference here is islets of Langerhans. That one difference. This is where we'll find the beta and alpha cells that produce insulin glucagon. Okay, so I always remember, what is it, Bi silver? I have a periodic table. Bi gold, silver. Bi for bi, beta produces insulin, and then Ag, alpha produces glucagon. And on the periodic table, Ag is silver, gold, one of the two, metal, all right? So there's islets of Langerhans. So when you guys are looking at this in lab, if you only see this and that's it, none of this, parotid. If you see islets of Langerhans, pancreas, okay? The beta and alpha cells, we don't require you like in lab to identify them, but you should know the function. Same in here, know the function. The tags on them, that you can't see it with a microscope to identify which is which. CCK, we've talked about this, stimulation of gallbladder. It also has an effect on the enzyme production, the pancreas really the glands producing and releasing the enzymes. And we've talked about all of these except for this last one, ribonuclease, nucleus, and nuclease, and then deoxyribonuclease. These break down DNA and RNA. We can produce our own nucleotides, which are the building blocks for RNA and DNA. Why not just take it from your diet? So when you break this down to the nucleotides, like say you eat a vegetable and you break down the DNA inside of it, you actually can break it down to nucleotides, recycle it into your own DNA. Actually, when you're building new cells, building new DNA from your diet, you can build those structures. Okay. And then bicarb, we've talked about this, and that is for neutralizing the chyme acid that's coming in. So we talked about, getting it down to these monomers. Where does it go? We talked about hepatic portal vein, going to the liver. Short fatty acids, shorter ones, and long fatty acids. How much C and H is the difference? No clue. Okay, short fatty acids go to liver. Longer fatty acids, those will get combined with a protein, typically become chylomicrons in the lacteals, and then travel to subclavian. Ooh, wow, we made it through digestive. Now we got to pull up metabolism. All right. So, digestion, that's the breaking it down, absorbing it, getting it into the bloodstream. Metabolism is where we talked about like building that glycogen in the liver, making ATP, using it to generate energy. Okay? That's what we're doing with the food. In reality, when you talk about the entire purpose of why we eat and breathe oxygen is to do one equation. We take glucose, we combine it with O2, we create CO2, water, 32 to 38 ATP, depending on the book you look at. That's really the entire purpose, is to generate ATP. Without ATP, you'll die. You actually would be at rigor mortis. That's what happens when you don't have ATP. Okay. So metabolism is just the chemical reactions that we're going to talk about. Anabolism, that's building. To build, we need energy, ATP. So I always think about like anabolic steroids. If someone takes anabolic steroids, they go to the gym, they build muscle, that takes energy and time. Catabolism is the breakdown and release of energy. It does not require energy. So I always think of like a cat pushes a vase off the table and it lands on the ground and we see this energy release. Okay? And the vase shatters everywhere. I saw a funny video the other day where the guy was sleeping and the cat I guess he had like a glass of water above him while he's sleeping and it knocked it down on his head in his sleep. It's funny. All right. Hydrolysis, using water to break. Dehydration is how we build. So we'll take those monomers, like two monosaccharides, two glucose molecules, pull the water out, they'll connect. That's how we build glycogen, for example. So macronutrients, really, protein, carb, fat. Water, you can't break down water technically, okay? So we just, water. We do break it down. I take that back. Okay. Micronutrients, minerals, vitamins, and really when we talk about westernized diet, we pick up a majority of it through our general macronutrients. Taking a secondary source isn't really hugely necessary. So ATP, that is our energy. Our bodies prefer carbs. The reason being that structure is very easy to run through this process. It's quick. It's easy. Think about it like this. If you eat some candy, what happens to your energy level? Right? Especially if like kids. Give them candy, sugar high. What follows the sugar high? Crash. Okay? Because they burn through that real quick. Energy source, crash. If you eat a straight protein meal, like a lean protein, let's say some fish or chicken, you feel full for a little, and then you're hungry pretty quick. Proteins we can break down pretty effectively as well and generate the ATP and use it. Now throw some fat into your meal. You go eat some like wings. Now everyone's gonna be craving wings, right? You go over to Taco Mac, you get some wings, and you feel like a fat potato for like 3, 4, 5 hours, right? Because it's fried, you're eating that skin, a lot of fat in there plus protein. You down it with some Coke, tons of carbs, you feel satisfied for a long period of time because it takes a long time for the fat to be broken down. And because it's high energy value, you produce lots of ATP over a long period of time. Hence, the satiety center is satisfied. Okay. So, a couple terms we look at: genesis, beginning, building. Okay. So, when we take in food and we have that glucose that we've broken down the monomers, we absorb them, and there's extra. We store it. We store it as glycogen. Where do we store it? Where we need it. Liver to distribute to the entire body, muscles to generate ATP for their function. So you're going to see primarily glycogen stored in the liver and in the muscle. How do we build structure? Dehydration. What is dehydration? Taking water out. Did that require energy to build, to do dehydration? Does it require energy? Yes. If I want to build that muscle, I got to put in the time and energy. So it's anabolic process. Glycogenolysis. Lysis is break. We're saying glycogen, break. This is where I break the glycogen down into the individual glucose so I can maintain that normal blood glucose level. What time of day would you say your blood glucose level dips? At night, middle of the night. Think about it. You ate dinner, 6, 7, 8 p.m., 10 p.m. I don't know what time you guys stay up till. Okay, I'm getting older, and like 10 is kind of like, um, but you eat dinner, and then you're fasting. You're fasting. What you ate is good for about 4 hours or so. Everyone's doing intermittent fasting through the night. Around, if you sleep at 10 p.m., around 5 p.m. or 5 a.m. or so, you usually start to stir. The reason you're starting to stir is your liver is undergoing glycogenolysis because your blood glucose levels have dipped. So you release this glucose into your body, and you'll notice you kick off the covers usually around then. You're hot. Why? Because you're generating ATP. That generation of ATP is very inefficient, and we produce heat. We don't produce straight energy. We also produce a good amount of heat. That's why we start to feel real warm in the morning, especially around that time, okay, after so many hours. So what do we do? This is that equation we're going to be learning. Intake, they use glucose because we know it's a 6-carbon structure. When we talk about like proteins, depending on the amino acid, the carbon structure changes. When we talk about fat, depending on how many chains on that tail, how long it is, the carbon number changes. But glucose, all the monosaccharides are always 6-carbon. So we can run a math equation. So we use glucose, that's from diet. We breathe in the O2. We undergo cellular respiration, and we produce CO2. That's what we breathe out. We generate water. Go stand outside tonight and breathe outside, and you'll notice, right? You'll see the steam. Okay, that's water. We urinate it out as well. And then ATP, 32 to 38 ATP. So remember, anabolism, building. We're building this structure. Catabolism is breaking down this structure. So catabolism, breaking down glucose, and it turns into CO2, water. Anabolism is we're going to take adenosine diphosphate. Di is 2. All it's saying is there's 2 phosphates on there. It has energy, but not as much. And there's even AMP, monophosphate, adenosine monophosphate. It has energy, but not that much. And what we're going to do is force inorganic phosphate, that P by himself, into the ADP and create a high energy bond on that third bond. And that's where we create triphosphate, adenosine triphosphate. That's what packs the punch. That's what we use for all our energy process. That's the currency for energy. Okay. Where do we produce ATP? I know all of you know it. What organelle? Mitochondria. What's the nickname for the mitochondria? Powerhouse of the cell. Everyone always knows powerhouse of the cell. Why is it the powerhouse? Because it's making ATP. The more mitochondria you have, the more ATP production. The more mitochondria you have, the more food you break down, the more rapid. So when you think about this, like long distance runners, why do they have stamina? Because they can produce energy over a long period of time. Through that training, the stamina builds. The cells start to produce more mitochondria in them. They're more mitochondrial rich. Okay? So they burn energy for a long period of time. They can maintain that ATP production and undergo cellular respiration for extended periods of time. Lots of energy, lots of sustainable energy. You look at your muscles in your body, muscles that work all day long, your core muscles, right? Leg muscles, they tend to be rich in mitochondria. They're your slow twitch muscles, what they reference it. Lots of ATP, so it can work all day long. Versus muscles like in your hand. These are fast twitch, quick movements. If I do this for just a couple minutes, my hand starts to fatigue. My fingers start to fatigue. Not as rich in mitochondria. They flip over to fermentation. And we'll talk about that as well. All right, I think this is a good stopping point. So we have another day, 2 days, day, yeah, another day and a half to cover metabolism. So I'm not worried about it. We'll make it through it. If we have time, we'll do review as well. Any questions before we sign off? So work on your lecture notes. Make sure you're filling them out. Okay. And I will see you guys Monday.